Hello everyone, welcome back. In continuation with the series of lectures in vasculitis, today we'll be discussing about small vessel vasculitis. So let's begin. So how do you classify small vessel vasculitis? So we had learnt about this in the revised Chapel Hill criteria that small vessel vasculitis can be classified as immune complex mediated vasculitis and ANCA-associated vasculitis. Okay, so the basic difference in your classification is that one set has an immune complex mediated vasculitis, the other has an ANCA predominant vasculitis. Okay, so how are these two different? Right? So in immune complex mediated vasculitis, you find evidence of immune complex deposition in the walls of the arteries or the vessels. Right? So there is immune complex, maybe which can be an IgG, IgM or complement deposition. These kind of immune complexes will be found in your vessel walls. ANCA-associated vasculitis, basically ANCA stands for anti-neutrophil cytoplasmic antibodies. Anti-neutrophil cytoplasmic antibodies. Right? So in this ANCA-associated small vessel vasculitis, where the arterioles, the venules and the veins are involved, there are antibodies produced to the neutrophil cytoplasm. Okay, so the pathogenesis is not completely clear, but in this ANCA-associated or ANCA-mediated vasculitis, due to an unknown autoimmune trigger, what happens is that the neutrophils are abnormally stimulated and they begin to express two kinds of receptors. The two kinds of receptors is what we call as the PR3 receptors and the MPO receptors. MPO stands for myeloperoxidase. Right, so we have PR3 receptors and MPO receptors which are expressed on these neutrophils, and due to an abnormal immune process, there are antibodies produced to this specific receptors which is the PR3 and the MPO, and hence these are what we call as your anti-neutrophil cytoplasmic antibodies. Okay, so anti-neutrophil cytoplasmic antibodies or your ANCA-associated vasculitis is further classified into two types, which is the anti-PR3 antibody or anti-PR3 ANCA and anti-MPO antibodies ANCA. Okay, anti-PR3 is also called as your c-ANCA. Anti-PR3 is also called as your c-ANCA and anti-MPO is also called as your p-ANCA. Okay, fine. So let us just put things back into perspective. We are seeing what is small vessel vasculitis. So small vessel vasculitis is vasculitis which involves the arterioles, the venules and the veins. It can be classified into two types as immune complex mediated and ANCA-associated vasculitis. Okay, so ANCA can be further classified as your PR3 and anti-MPO antibodies. So how are these two different when it comes to the histopathological examination? On the histopathological evidence, when you take your vessels, so immune complex mediated vasculitis shows evidence of leukocytoclasis. We had discussed this in the basics of approach to vasculitis as well. Leukocytoclasis means that there is abnormal netosis, which is your neutrophil extracellular traps, and the neutrophils themselves burst open and they are degraded. So there is leukocytoclasis, there is a leukocytoclastic vasculitis. In your ANCA-associated vasculitis, this predominantly results in a fibrinoid necrosis, right? So it predominantly results in a fibrinoid necrosis. Fibrinoid necrosis means what? There is damage or a necrosis of all the three layers and there is extravasation of the blood outside. This is what we call as fibrinoid necrosis. So a necrotizing vasculitis is your ANCA-associated small vessel vasculitis. So what are the examples of your immune complex mediated vasculitis? We have your anox shown in Purpura, which is also called as IgA vasculitis, right? Then we have good pasture syndrome. Then we have hypocomplementemic urticarial vasculitis. All these are examples of immune complex mediated vasculitis. So when it comes to the ANCA, we have the c-ANCA and the p-ANCA. Depending upon the type of fluorescence or immunofluorescence that they display, this is how it is classified. So c-ANCA predominantly shows the evidence of your immunofluorescence to the cytoplasm of neutrophils. The cytoplasm of neutrophils, whereas p-ANCA stands for perinuclear, where the staining is predominantly perinuclear. So this is your p-ANCA. Okay. So where do you find this c-ANCA or your anti-PR3 antibody ANCA? So this is more common in GPA. So vaginous granulomatosis or GPA more than your microscopic polyangiitis and renal limited vasculitis. Anti-MPO ANCAs is more seen in your, again it can be seen in up to 40% of the patients with your microscopic polyangiitis, and it can be seen in EGPA as well. So whenever we speak about ANCA mediated vasculitis, remember GPA, MPA and EGPA. Immune complex mediated vasculitis, these are the examples. So the other causes where ANCA can be positive includes autoimmune hepatitis, primary sclerosing cholangitis, rheumatoid arthritis, IBD, infective endocarditis. These are the other conditions where you can have ANCA positivity. Okay. So this is about the major differences between your immune complex mediated and your ANCA associated small vessel vasculitis. Okay, fine. So let us start off with your ANCA associated vasculitis, which is your GPA, MPA and EGPA. Clear? So first let us start with GPA and MPA. So where do you find these kind of small vessel vasculitis? It's more common in the age group of more than 40 years and both males and females are affected. So first, when we speak about granulomatosis with polyangiitis, previously it was called as vaginous granulomatosis. It was previously called as vaginous granulomatosis. Okay. So the hallmark feature about your GPA is that there is involvement of your ENT, your ears, nose and throat involvement is very, very common in vaginous granulomatosis. Okay. So what are the different clinical manifestations? First, you have to remember your upper respiratory tract manifestation. So they present with history of recurrent rhinitis and recurrent sinusitis. Recurrent rhinitis and recurrent sinusitis with history of recurrent staphylococcal sinusitis. Staphylococcal sinusitis. Okay. So there is history of recurrent rhinitis, sinusitis, predominantly staphylococcal infections. Okay, fine. So that is about your predominant upper respiratory tract infections. Then ear involvement, how does it present? It presents with history of recurrent chronic serous otitis media. Chronic serous otitis media. So history of recurrent serous otitis media, how will they present to you? History of recurrent ear fullness and history of recurrent maybe a Grommet insertion and so on. So this is your serous otitis media. Then very, very characteristically they present with midline lesions and they are destructive lesions, midline destructive lesions. So this can result in destruction of the septum of the nose, it can result in destruction of the palate. Okay, so it can result with midline destructive lesions, destroying the septum, destroying the palate, and it may be very confused with your midline granulomas or your especially your NK cell lymphomas and so on, which can cause chronic destruction of the midline. Right, so there can be destruction of the septum, there can be destruction of the palate resulting in palatal perforations, and a characteristic clinical finding is that it can result in this appearance which is called as the saddle nose deformity. So you can have a saddle nose deformity as well. As far as your throat manifestation is concerned, it can be associated with subglottic stenosis. It can be associated with subglottic stenosis. Okay, so this is how your granulomatosis with polyangiitis presents with recurrent rhinitis, recurrent staphylococcal sinusitis, otitis media, midline destructive lesions, subglottic stenosis, and remember saddle nose deformity. Okay, so this is about your GPA. Now let us look at the other manifestations with which GPA can present. When it comes to the lower respiratory tract, you find evidence of cavitatory lesions. Can you see evidence of cavitatory lesions? You can find evidence of opacities as well. So multiple cavitatory lesions, opacities are all also characteristic of vaginous granulomatosis. Then Renal involvement is also very common. So more than 90% of the individuals present with predominantly upper respiratory tract manifestations. Lower respiratory tract manifestations can be seen in more than 80% of the individuals. Renal involvement can be seen in up to 50 to 60% of the individuals. Okay, and how are they going to present the renal manifestation? It presents mainly as type 3 rapidly progressive glomerulonephritis. Okay, type 3 means what? When you look back in the chapter of glomerulonephritis, this is a pauci-immune glomerulonephritis. So ANCA-associated vasculitis result in a pauci-immune glomerulonephritis where there is no evidence of immune complex deposition in the biopsy, but you find evidence of a rapidly progressive glomerulonephritis. So if this is your glomerulus, you find rapidly progressive glomerulonephritis characterized by hematuria, proteinuria, and the characteristic histopathological evidence of crescent formation. Crescentric glomerulonephritis. Okay, crescent formation. Right? So this is about your renal manifestations. Okay, in more severe cases in pulmonary involvement, they can also present with something called as diffuse alveolar hemorrhage, where they can bleed into the alveoli and present with massive hemoptysis. Massive hemoptysis. Okay. So these are all the various major clinical manifestations of granulomatosis with polyangiitis. Okay, when we look at the minor clinical manifestations, so what are the minor clinical manifestations they can present with? Joint involvement, they can present with arthralgias. They can present with arthralgias, and vasculitis involving the vasa nervosum. There can be involvement of the vessels that supply the nerves themselves, and hence this can result in mononeuritis multiplex. It can result in mononeuritis multiplex, where different nerves in different patterns of involvement can be present. Right? So no two anatomically contiguous nerves are involved. Different nerves are involved. This is your mononeuritis multiplex. Ocular involvement can involve scleritis, and you can have pseudotumor formation. Lacrimal gland enlargement can also be present. Right? So this is about the various clinical manifestations of your vaginous granulomatosis or granulomatosis with polyangiitis. Okay? So what are we discussing? Let us just put things back into perspective again. We are discussing small vessel vasculitis, under that ANCA-associated vasculitis, the first of which is your granulomatosis with polyangiitis. Okay, fine, right. Now, what about your microscopic polyangiitis? So, before we move on to microscopic polyangiitis, let us just look at this once more. So, in your ANCA-associated vasculitis in GPA, what is the most common type of ANCA which is found? It is your c-ANCA or your PR3 ANCA. But when we speak about microscopic polyangiitis, you find evidence of both c-ANCA as well as p-ANCA. Okay, let us be clear. Now let us move back to microscopic polyangiitis, which is the second prototype which we have to be learning in small vessel vasculitis. So, microscopic polyangiitis is more common in males than females. It has more predominant constitutional symptoms unlike the GPA, and it does not have any upper respiratory tract clinical features. It has predominantly lower respiratory involvement with diffuse alveolar hemorrhage, and massive hemoptysis can be a presenting feature of MPA as well. So, you have to remember certain differentiating features of MPA from GPA is that more prominent skin involvement and almost 100% renal involvement, again presenting in the form of a type 3 RPGN. Type 3 RPGN. Okay, ocular involvement and joint involvement are rare. So, if I just put GPA versus MPA, what is more common in GPA? Upper respiratory involvement, which is not there, and renal involvement, which is there in both, but it is more so common in microscopic polyangiitis. Ocular involvement and joint involvement is there in GPA, which is not there in your MPA. And skin involvement in the form of palpable purpura, It is more common in MPA, which is not so common in GPA. Okay, clear? So this is about your microscopic polyangiitis. Alright, so that is your granulomatosis polyangiitis and this is your microscopic polyangiitis. Fine. So let us look at the management of granulomatosis with polyangiitis and microscopic polyangiitis more in detail. So granulomatosis with polyangiitis, especially if it presents with diffuse alveolar hemorrhage kind of pattern or a rapidly progressive glomerulonephritis kind of pattern, then these are life-threatening conditions. Okay, so if there is an RPGN or if there is a diffuse alveolar hemorrhage, then a plasma exchange is definitely indicated because they are not very responsive to your conventional treatment. So especially in a patient presenting with DAH, if you are suspecting that this could be due to small vessel vasculitis, immediately go ahead, do a renal biopsy or you do your ANCAs, prove that there is evidence of small vessel vasculitis and go ahead and do a plasma exchange. So in patients where this is a more sinister kind of involvement, slowly progressive, there is only involvement of ENT or tracheal stenosis and so on, then you can go ahead with a high dose IV methylprednisolone induction, which is about 500 mg to 1 gram of IV methylprednisolone induction, which is given for about 3 days, followed by you convert it into oral steroids and you continue it for around 1 month to 2 months and try and taper it down over 6 to 7 months along with a cyclophosphamide based induction therapy and continuation with oral cyclophosphamide or certain other immunomodulatory drugs may also be required. Okay, so this is about how you manage your GPA and MPA. Clear? Fine? Okay. Now let us move on to the next type of small vessel vasculitis, which is EGPA. EGPA stands for Eosinophilic Granulomatosis with polyangiitis. So EGPA stands for Eosinophilic Granulomatosis with polyangiitis. Okay. So how does EGPA present and how is it different from your GPA? So as the name suggests, EGPA is a type of small vessel vasculitis. It is an ANCA mediated vasculitis and the predominant ANCA that you find here is the p-ANCA. Okay, fine, or it's also called as the anti-MPO ANCA. So here, as the name suggests, there is lot of eosinophilic inflammation. And the predominant upper respiratory symptoms which they present is allergic rhinitis. And it is very important that they are most oftenly confused with a difficult to treat asthma. It predominantly presents with allergic rhinitis and a difficult to treat asthma kind of picture, right? So they present with a long period of latency where you have recurrent episodes of asthma with peripheral eosinophilia. One important thing that you have to remember that whenever you give Montelukast, right? Montelukast in fact increases the severity of illness in these patients. So it paradoxically increases the severity of illness in these patients. Followed by the asthmatic phase, these patients go into a vasculitic phase where you may find evidence of vasculitis in the later stages, right? So in this illness, there is infiltration of eosinophils into multiple tissues, right? So if there is infiltration of eosinophils into the esophagus and infiltration of eosinophils into the stomach, it results in eosinophilic gastroenteritis, eosinophilic esophagitis. This esophagitis is going to present as episodes of dysphagia. And when you do an endoscopy, what is the characteristic feature you find? You find something called as feline esophagus. Feline esophagus or trachealization of the esophagus is a characteristic feature of eosinophilic esophagitis. Eosinophilic gastroenteritis, you may find the evidence of few submucosal hemorrhages and they present in the form of chronic diarrhea as well. Then there can be eosinophilic infiltration into the myocardium. They may present as myocarditis with heart failure, reduced ejection fraction kind of a picture can also be present. Eosinophilic inflammation and vasculitis of the vessels that supply the nerves can result in neuropathy. And what type of neuropathy do you get? You get a mononeuritis multiplex. You get a mononeuritis multiplex pattern. And this can also result in a type 3 RPGN, rapidly progressive glomerulonephritis. Okay, so this is about the varied clinical presentations with which EGPA can present as well. So what about the treatment? Treatment again is with systemic steroids, and if there is an RPGN pattern, you need to treat them with cyclophosphamide. Okay, fine. So this is about your different ANCA-mediated vasculitis. Okay, so now that we have learned about the different ANCA-associated vasculitis, we will be looking at the immune complex mediated vasculitis, which is under your small vessel vasculitis. So in immune complex mediated vasculitis, your ANCAs will be negative, right? And what type of vasculitis do you find here? You find a leukocytoclastic vasculitis, right? And here the skin involvement is more prominent. And if you do a skin biopsy, it shows the presence of immunofluorescence, right? It shows the deposition of deposition of immune complexes, and immunofluorescence will be positive. And will you find granulomas? Granulomas are absent in your immune complex mediated small vessel vasculitis, right? Fine. So what are the prototypical diseases which are found under your immune complex mediated small vessel vasculitis? So here you have your primary disorders, which includes Enoch-Schonlein Purpura. Okay, so we have Enoch-Schonlein Purpura, then we have your good pasture syndrome, hypocomplementemic urticarial vasculitis, These are examples of small vessel vasculitis, immune complex mediated. Then secondary to what? Secondary to drugs. What are the drugs that can cause small vessel vasculitis? Drugs such as hydralazine, drugs such as propylthiouracil. All of these can cause immune complex mediated small vessel vasculitis. Secondary to other connective tissue disorders like RASLE. Okay. Then single organ immune complex mediated vasculitis includes your primary CNS vasculitis, primary cutaneous angiitis. These are examples of single organ vasculitis. Okay. So this is about how you classify your different immune complex mediated small vessel vasculitis. Then let us understand the pathogenesis. How does these immune complex mediated vasculitis actually originate? So in your immune complex mediated vasculitis, there is an abnormal autoimmune trigger. Yes, there is an abnormal autoimmune trigger. This abnormal autoimmune trigger is going to stimulate excessive amount of neutrophils. So it is causing excessive activation of neutrophils. So there is excessive activation of neutrophils. This excessive activation of neutrophils results in abnormal netosis. There is abnormal netosis, means what? Netosis refers to neutrophil extracellular trap formation, and that itself becomes neutrophil extracellular trap formation, and that itself becomes disorganized. Okay, this abnormal netosis results in destruction of the neutrophils themselves. It results in destruction of the neutrophils themselves with accompanying inflammation, and this is what we call as leukocytoclasis. Okay, fine. So this is about how your immune complex mediated vasculitis actually originates. So let us move on to the prototype disease which we have to learn under your immune complex mediated vasculitis, and this is what we call as your Enoch-Schonlein Purpura or HSP. The other name is IgA vasculitis. Okay. So HSP is commonly seen in the pediatric age group. If it is found in adults, it can be found in young adults, and it usually has a poorer prognosis in adults. Okay, so we have learned that the common feature for most of the immune complex mediated vasculitis, especially the small vessel vasculitis, is that there is a predominant skin involvement in the form of what? Bilateral symmetric non-thrombocytopenic. So there is no low platelet count, non-thrombocytopenic palpable purpura. So there is a palpable purpura which is symmetrically involving both the legs. So it involves the shins, it involves the buttocks, it predominantly involves the extensor aspect of the limbs. Okay, shins, buttocks. So this is a non-thrombocytopenic palpable purpura, bilaterally symmetric, which is a very characteristic feature of your inoxonline purpura or IgA vasculitis. Since this is a small vessel vasculitis, the characteristic feature is the presence of this purpura. Okay, fine, right. Then another characteristic feature is a joint involvement, and this is a asymmetric, predominantly knee joint involvement, which is a migratory, non-erosive oligoarthritis. Okay, so asymmetric, every word is important. Asymmetric, it usually involves one of the joints. It does not involve symmetrically similar to rheumatoid arthritis. No, it is an asymmetric joint involvement. Most commonly involved joint is the knee joint. It is migratory in nature. What is the meaning of migration? Migration means that there will be a small joint inflammation and it completely subsides, then the next joint is involved. Similar to where do you find migratory arthritis? You find it in rheumatic fever, acute rheumatic fever, similar to that. This is a non-erosive arthritis and it is an oligoarthritis because at once less than 4 joints are involved. Okay, it's an asymmetric, migratory, non-erosive oligoarthritis predominantly involving the knee joint. So you have bilateral palpable purpura with knee joint involvement. Apart from that, you can have GI involvement, right? Because this vasculitis can to a certain extent involve the GI vessels as well and can present hemorrhage, can present as massive GI hemorrhage, and it can cause bowel ischemia, right? So how does bowel ischemia present? It presents with post-meal pain similar to angina. In the heart, you have angina here, and this is what we call as bowel angina. So these pains especially are post-meals. They are aggravated post-meals. Then you can have scrotal edema, and the most dreaded complication is an intussusception. Okay, the most dreaded complication which has a very poor prognosis is an intussusception, right? So this is about the various GI manifestations. As far as the renal manifestations are concerned, in children you have asymptomatic macro or micro hematuria. In adults you can have macro hematuria as well. But in adults, sometimes you can have an RPGN kind of picture, and in many others it can progress to chronic kidney disease. Mainly it can convert into an IgA nephropathy. Because of an associated IgA nephropathy, it can progress to a CKD as well. Okay, so the characteristic clinical features you have to remember as far as your HSP is concerned. You have a bilateral symmetric palpable purpura, asymmetric oligoarthritis which is migratory in nature, non-erosive, predominantly involving the knees. You can have GI involvement which can result in GI bleeds, bowel angina, most dreaded complication, intussusception, asymptomatic microhematuria or microhematuria can be present as a renal manifestation, right? So this is about your inoxonline purpura, which is an immune complex mediated small vessel vasculitis, right? So what is the management of HSP? In children most often it is usually a self-limiting disease. In children most often it is a self-limiting disease. Only if there is an RPGN kind of picture or if there is a severe GI hemorrhage, then you have to give steroids. So steroids will be the treatment of choice in these kind of conditions. Okay. Let us move on to the next immune complex mediated small vessel vasculitis, which is cryoglobulinemic vasculitis, right? So what is the meaning of this cryoglobulinemic vasculitis? So what are cryoglobulins? As the name suggests, cryo means cold and globulins basically refers to the immune complexes. Okay, so cryo means cold and globulins basically refers to the immune complexes. So cryoglobulinemic vasculitis is a type of vasculitis where the immune complexes are formed at lower temperatures. The immune complexes are formed at lower temperatures and they precipitate at 4 degrees Celsius, whereas on rewarming the complexes are lost, right? So they do not precipitate. The precipitate clears, the complexes clears in a cryo tube, right? All of this can be demonstrated in a cryo tube. Okay, so this is the basic meaning of cryoglobulins. So cryoglobulinemic vasculitis is when these kind of cryoglobulins, which are immune complexes, are deposited within the vessels. Okay, so cryoglobulins are immune complexes and they precipitate at lower temperatures and they clear off by rewarming. What type of a vasculitis it is? Yes, this is a small vessel vasculitis, right? And is this an ANCA-associated? No, this is an immune complex mediated vasculitis. Okay, fine. So, what are the etiologies? The most common etiologies are infectious in nature, hepatitis B, hepatitis C, HIV and subacute bacterial endocarditis. Cryoglobulins are classified into 3 types. So, we have type 1, type 2 and type 3. Okay, there are certain subtle differences between these 3 types. So, type 1 basically comprises of monoclonal IgG or IgM are the types of immune complexes that are formed. It's monoclonal IgG or IgM and it is RF factor negative. These are usually rheumatoid factor negative. Type 2 comprises of polyclonal IgG and monoclonal IgM and type 3 is polyclonal in nature. Type 2 and 3 are RF positive, rheumatoid factor positive, and when both are present, if type 2 and 3 both are present, it is called as mixed cryoglobulinemia. It is called as mixed cryoglobulinemia. Okay. So what are the examples? Type 1 cryoglobulins is seen in Waldenström's macroglobulinemia, which is usually associated with hyperviscosity syndromes. It is usually associated with hyperviscosity syndromes. Type 2 is seen in hepatitis C. Type 3 cryoglobulins are seen in SLE. Okay, fine. So let us just make things a little bit more clear. What are we talking about? We are talking about cryoglobulinemic vasculitis. We have understood what are cryoglobulins. Cryoglobulins are immune complexes which precipitate at a colder temperature and then they get deposited into the vessels. So it can be classified into 3 types, type 1, 2 and 3. Now after our discussion, you would have understood that cryoglobulins can be found in 3 major types of conditions. One, it can be autoimmune. Secondly, it can be secondary to malignancies. Thirdly, it can be seen associated with infections as well. Okay, so how do these present? Predominantly because it's a small vessel vasculitis, yes, they are going to present in the form of palpable purpura. Purpura are basically small bleeding spots on your skin. Then cryoglobulins can also involve the medium vessels to a certain extent and hence they can result in gangrene. If there is joint involvement, you can think of SLE. GI involvement, yes, it is associated with SLE, right? So they can have small vessel involvement. Certain amount of medial vessel involvement can result in ulcers. It can result in vasculitic ulcers. It can result in gangrenes. It can result in GI bleeds. Okay, in the kidney, it results in a membranoproliferative glomerulonephritis kind of pattern which can result in RPGN as well. Peripheral nervous system involvement, yes, there can be evidence of mononeuritis multiplex. Okay, so an SLE patient presenting with vasculitic ulcers, okay, you have done a Doppler, you don't find evidence of any thrombosis and you are thinking that this is a vasculitic ulcer, you have to check for cryoglobulin levels to rule out a cryoglobulinic vasculitis. Clear? So, what are the investigations that you want to do? So, if you do a immunofluorescence from the skin, it will be positive, right? The next would be a cryocrit test. Cryocrit is a specialized method of detecting these cryoglobulins where you find a precipitate at 4 degrees Celsius, right? And this is also characterized by hypocomplementemia. C3 or C4 levels will be low most of the time C4 levels will be low. Treatment depends upon which type of cryoglobulinic vasculitis you are dealing with. If it is a type 1 which is seen in your Waldenstrom's disease with hyperviscosity, certain malignancies, you will have to go ahead with Plex, steroid or cyclophosphamide can be tried. In type 2 and 3 cryoglobulinemic vasculitis, Rituximab is the treatment of choice. Okay. So, with this we have come to the end of our discussion on small vessel vasculitis. Thank you.